Then I hear the clock ticking, think of you, or called up in circles. Confusion is nothing new. Flashback to all night, all those left behind. A suitcase of memories. Time after some time to think. Walking too far away.
Hey guys, good morning everybody. We're going to go ahead and get started. I know we'll probably have some people coming in. It's okay. First, I just wanted to take some time to welcome you to the class. This class is actually, we are able to have this class as a result of a grant that was awarded to the UT Health Science Center San Antonio. So, and it's set up to provide continuing education, and it's set up to target South Texas, and Dr. Schillerstrom will give you a little bit more detail on that as well. But I also want to take the time here to say that you guys have a great presenter today. He's actually a great asset to APS, to Adult Protective Services. Through his collaboration with APS, we have been able to protect our elders, some of our elders in our region. So again, my name is Jesse Gonzalez with Adult Protective Services, and welcome to the class, and thank you for taking the time to be here.
Good morning, everyone. My name is Joseph Agba. I'm from the University of Texas Health Science Center, South Texas GEC, Department of Psychiatry, Division of Medicine. And again, we're very proud to present to you Dr. Schillerstrom to bring you an intensive, thorough, very informative educational presentation today, all day. So consider yourselves lucky. So let me do some paperwork and lock the doors. Okay. So let me get through some paperwork and some housekeeping real quick. The most important form for today is the statement of attendance for those who are seeking continuing education credits and those who are seeking certificate of attendance. As you see on our first page here, it has the amount of hours in which CEs are available. Page 2 shows you the form you're going to turn in at the end of today's conference. So put down the credits you attended, your signature, your name, and most importantly, your email address, because everyone will receive your certificates via email. And you must attend 100%. It's either all or nothing. All in or all out. And of course, our disclosures, our objectives. Behind the last page is the faculty, party one, and the planning committee. Second page is the participant profile. This is a voluntary survey of each individual. What this does for us, if you fill this out, it helps us bring on the grant which was awarded to us. This will bring future grants to award to other companies and allow other people on it. So we can provide other companies for free or for low cost. And like for instance, this is the free conference, free CEs. This is done because people previously filled in their surveys. And this was to bring this to you, so you can just pass the paper forward. We appreciate that. This conference is being videotaped, so what you say, what you do. If you want
He's talking to me.
If you would like a free DVD, go ahead and fill this out, place the amount you want. Don't put 100, that will, oh my gosh, that will ruin my year. Just put down the amount you want and agree that we will share this educational program to fulfill the promise to help Alzheimer's and dementia care in South Texas. If you like this conference, you're going to love our Summer Institute of Aging. This is our week-long conference coming up in late June. It's $20 per day or $90 for the week. If you are a VA, you have the special pricing, so go ahead and fill this form out, and you will be the first to be seated in that conference. So it's a very good conference. Ask me. Our next sheet is the schedule of events for this year for the South Texas GEC, which is the department I'm from. As you see, we have a full schedule, a full year ahead of us. And on the back, we have even more free educational programming. Every Thursday, we have the Grand Rounds and Journal Club, which takes place at the Audie L. Murphy VA Hospital here in San Antonio. You're more than welcome to come and enjoy a 1-hour didactic educational program given to you by the best doctors of the VA and surrounding area. So if you see a topic you like, go ahead and give us a call, and we'll give you some instructions how to get there, and we'll be more than happy to have you there. Our next to last sheet, no, this is our last sheet, is our YouTube and links to our website. At our website you can find all sorts of videos. At some point in the future you'll find this video on the site, and you'll find yourself other videos such as the grand rounds and the club that have been taken in the past. Without further ado, let me introduce Dr. Jason Schillerstrom. He is an associate professor of psychiatry at the University of Texas Health Science Center. He completed his medical school psychiatry residency and geriatric psychiatry fellowship at UTHSCSA. Dr. Schillerstrom established and directs the UTHSCSA Geriatric Psychiatry Clinic that specializes in cognitive impairment in depression in the elderly. This clinic serves as a interdisciplinary training site for medical students, psychiatry residents, pain medicine fellows, and nurse practitioners. In addition, Dr. Schillerstrom is a primary psychiatry consultant for the Texas Region 8 Adult Protective Services, where he performs forensic psychiatry evaluations and is a member of the National Organization Research Committee and studies cognitive correlation of decision-making capacity, self-neglect, and financial exploitation in vulnerable elders. So please help me in welcoming Dr. Jason Schillerstrom.
So it's great to be here. As was said previously, this whole symposium was funded by a grant. It's through Michelle Saunders, South Texas Geriatric Education. And what would happen is that I would talk at the state conference, the state APS conference, which is always here in town, and then someone would come up and say, who gives talks like this in Abilene? I don't know where Abilene is. And so then, so what was clear was that there's certain areas that that might benefit from similar type of discussions, particularly in South Texas and along the border. So when the grant was put in, the focus is certainly our colleagues here, y'all here in San Antonio, but actually, to tell you a secret, y'all are our pilot audience, because the groups within the grant, the big mission of the grant is to bring education like this specifically to the Valley, Lower Rio Grande Valley, and to El Paso. So there's these other APS regions that we're wanting to help out to teach. So any feedback that y'all have, through the eyes of, I think I see so many familiar faces in the audience that a lot of y'all have heard what I said before. So if you can kind of put on your hat, what would someone who's never heard me want to learn, and if you could give us that feedback so that we can more effectively help out our APS colleagues, again, down in Arlington, McAllen area, as well as El Paso, we would be very grateful. So with that, today the focus is on dementia-related disorders. The first talk will be an overview of dementia itself. The second talk will be focused more on executive function and decision-making capacity and how those assessments are done and what the challenges of those assessments are. After that, we'll break for lunch. After lunch, we'll come back and we'll start, it'll be a more pharmacology-focused talk. We'll talk about different medication strategies for managing dementia-related behavioral disturbances, the hitting, the biting out, all that kind of stuff that we have to target. So it'll be a very pharmacology-focused talk. And then the wild card that I've changed up on jokes. The wild card that I've put at the end, we'll talk about alcohol. So I figure by the end of this day, we're all going to need a drink. And so, man, the all or nothing policy, you will definitely need a drink. And so I thought we would wrap up and we'll talk about alcohol and alcohol-induced cognitive impairments. So So that's the agenda for today. Again, we're going to start with dementia-related disorders. So what I want you to get out of the first hour and a half or so is know the diagnostic criteria for dementia. It is a real illness with a real set of criteria that one has to meet to be diagnosed with dementia. We don't just look at someone and say, well, they kind of look demented. So there actually is a set of criteria. The other real learning point that I want you to walk away from is just knowing that there's different types of dementia. Alzheimer's disease and dementia are not synonyms. Alzheimer's disease is a type of dementia. And so what I want you to learn is that there's 1,000 ways, as it turns out, to be demented. But there's 4 key types that we see most commonly that I want you to be able to distinguish between. And so that's Alzheimer's disease, Lewy body dementia, frontotemporal dementia, and vascular dementia are what we see most commonly. So we'll go over the different types of dementia, talk about different theories, what might be causing each, particularly Alzheimer's disease. I get asked that all the time. You know, my dad has Alzheimer's disease. What are the chances that I'll get it? Right? That's a very common question. So we'll talk about genetics. So we will, throughout the day, we are going to kind of dive into science, but we'll try and kind of rescue you from that so if we get too deep into the science. Hopefully, just bear with me, and we'll make it real short. So let's begin with the criteria. So the criteria as they stand now, there's a new whole set of DSM criteria coming out. But the criteria as they stand now are to have dementia, you have to meet these categories, right? So within the dementia diagnostic category, dementia is the broad diagnostic category, dementia disorders. But then there's lots of different ways to be demented. And so Alzheimer's disease is a type of dementia, Lewy body disease is a type of dementia, vascular dementia is a type of dementia. A lot of different types of dementia, but the overarching diagnostic category is dementia. So in the hallmark feature as it stands right now for dementia, criteria number 1 is that you have to have memory. And what I want you to appreciate is that there's different types of ways that your memory can actually be impaired. It's very common that I hear, you know, I don't think they have dementia because their memory doesn't seem that bad. You know, they might forget words or names or that kind of thing. Their memory doesn't seem that bad. There's lots of different there's different ways your memory can be impaired. Depending on how your memory is impaired, that can inform what type of dementia you have. So nonetheless, you must have memory impairment. If you don't have memory impairment, you can't have dementia because that's the number 1 criteria. And then you have to have at least one of the following of these other neuropsychological impairments. And so that would be aphasia, apraxia, agnosia, and executive function impairment. And we'll talk about what each of those are and how we assess those. The cognitive deficits have to lead to social, occupational impairment. So a lot of times I'll do a capacity assessment perhaps. This doesn't happen a lot of times, but sometimes I'll do a capacity assessment. So we'll go out and we'll do the capacity assessment, and we'll do the neuropsych testing. We'll do their memory testing or their executive function testing, whatever it is. And they might fail these cognitive measures. They might have measurable memory impairments or executive function impairments. But there'll be no evidence that the person's functionally impaired. None. So they're paying their own bills, they're doing their own grocery shopping, they're managing their own medications, they're managing their money. There's no evidence of disability. So it doesn't matter how badly a person does cognitively, if they don't have comorbid functional impairments, then you can't have dementia, right? And so you have to have functional impairments to have dementia. And not only do you have to have functional impairments to have dementia, but the functional impairments have to be caused by the cognitive deficits, right? So, there could be a person who, I don't know, lost their legs in the war and they can't walk anymore, so they're functionally impaired. They're not functionally impaired through cognitive impairment, they're functionally impaired through physical impairment. So we have to distinguish between that. And then finally, these cognitive deficits cannot be caused by delirium. And so delirium is more of a transient cognitive impaired state. The most common cause of delirium in elders is what? Urinary tract infection. Oh my gosh. And so when we're doing the capacity assessments or the dementia assessments, we have to be certain that that what we're seeing isn't caused by some sort of underlying medical condition that's leading to these fluctuations in consciousness or attention. So these are to have a dementia diagnosis, you have to meet these criteria, these medically defined criteria. So go back to memory impairment first. I told you there's different ways that memory can be impaired. The first split in the algorithm, in the branch, is to figure out does the elder, it's usually elders, does the elder have promptable memory impairments or do they have non-promptable memory impairments? And so that's really what starts to inform the type of dementia that a person will have. So for example, what we might do is we might say, okay, I'm going to give you 3 words, and I want you to remember these 3 words, and we'll pick 3 words. We'll pick, checkers, telegram, and saucer. Okay, I want you to remember these 3 words: checkers, telegram, and saucer. And then we'll distract them, and then we'll come back and we'll say, okay, what were those 3 words? And so if they say, well, I don't remember what those 3 words were, then what we'll do is we'll say, okay, well, one of them was a game, right? And if they say, oh, yeah, checkers, that's right, now I remember, the game was checkers. That's an example of a promptable memory impairment. Their memories come back when they have prompts, right? If you give them hints or clues, then the memory comes back, right? Well, one of them was a dish. Oh yeah, the saucer. Now I remember the saucer, right? So those are examples of promptable memory impairments. If you say, well, one of them was a game, and they say, oh, I don't know. Then you say, well, was it checkers, chess, or whatever, Monopoly? And they say, I don't know, was it Monopoly? So then they would have non-promptable memory impairments. So the prototypical dementia that is associated with non-promptable memory loss is Alzheimer's disease. For patients who have Alzheimer's disease, it doesn't matter how many hints or clues you give them, the memories never come back, right? And in real life, the way this often translates is, it's the Alzheimer's patients who keep telling you the same stories again and again and again, as if they're telling it for the first time, right? Then they never lay down the memory that they already told you that story, so it just repeats itself again and again and again. So Alzheimer's disease is a great example of a dementia that's associated with non-promptable memory impairments. In contrast, Parkinson's disease or Parkinson's dementia has promptable memory deficits. You ask them what was the game, and they'll say, oh yeah, it was checkers, right? So in Parkinson's disease, the parts of the brain that encode memory are spared. So they're able to encode the memory. What Parkinson's disease affects is the part of the brain that allows you to retrieve the memory. So as soon as you help them with the retrieval process, the memory springs back. Okay? So again, when you're working with elders, when we're trying to look at memory, what type of memory problems do they have, the first branch is, do they have promptable memory impairments or non-promptable memory impairments? That's the first thing we're trying to do. Going on to the other diagnostic qualifications in the number 2 criteria. So the first is aphasia. So what aphasias are, aphasia is when you struggle to get, it's like I feel aphasic. It's when you struggle to get the words out despite having intact hardware to get the words out, right? So it's a deficit of speech, okay? But you have it, but the speech deficit is central. It's in the brain, right? And so it's not that you have speech deficits because your tongue has been denuded, for example, right? It's not because, in my case, you're like developing laryngitis or whatever, right? It's so the hardware is intact, it's just you cannot get the words out. These are basic deficits of speech. And so most commonly, the way that we'll test this, if it's not obvious, sometimes it's very obvious that the person has these aphasic deficits. If it's not obvious, then we'll start to probe for it. And the way we'll test for it, for example, is we'll say, barring an item from the mini mental state exam, we'll say, okay, well, repeat what I say. No ifs, ands, or buts. And they have to just repeat no ifs, ands, or buts. And so we specifically use that phrase because it challenges people to use words as nouns that are not commonly used as nouns, right? And so therefore it's more likely to elicit these aphasic type deficits. So again, if you a person with aphasia, if you say repeat what I say, no ifs, ands, or buts, a lot of times it comes out just sort of jumbled. No ifs, ands, and buts, right? And, they just cannot spit it out. The other way we see it most often, clinically, is with word finding difficulties. So just in the context of a normal interview, they won't be able to use the word that they intend to use. So, this past week, I had a lady in clinic saying, that she went out to her backyard and she had to get one of those, that thing. You put water in it. It's like you put water. You carry water, and she just could not get the word bucket out. Right? She's trying to tell me that she went to her backyard to get a bucket, and you can see bucket right there on the tip of her tongue, and you just want to reach in, you want to grab it, and pull out the word bucket. Anyway, and so she has an aphasic deficit. She has a word finding problem, right? She cannot spit out the word that she intends to use. So the way, again, clinically that we'll go after this is we'll have them identify objects. And what we'll do is, you have to challenge them with words that are not commonly used. So for example, I'll take my glasses off. And I'll say, well, what are these called? And a lot of times they'll be able to say, well, those are the glasses, right? And so then we'll get more specific. We'll say, okay, well, what's this clear part right here? What's that thing? Like, what's that part of the glasses? And that's when the aphasic deficits will start to come out. They'll say, well, that's the glass that you see through. It's a magnifier. Well, it's not a it's like a magnifier. They cannot get the word lens out, right? Or they can't get the stem out or the nose piece out, that kind of thing. So again, you can't just say what's a television. You have to point to parts of the television, words that are less common. So that's it. That's aphasia. Those are examples of basic deficits in how we test them. The next one is apraxia. And so apraxia is if they'll have impaired motor movements, again, despite having intact motor hardware. Okay? So again, they're not apraxic because, say they had a stroke, for example. If you have a stroke, then if you have a stroke on the left, in your left motor strip, you struggle with your right hand. The hardware's been knocked out, right? You've had a stroke. But in apraxic deficits, all the hardware's in place, and yet you still cannot function like you need to. So again, clinically, what we'll do is we might hand a person a piece of paper, and we'll say, I want you to take this piece of paper in your left hand, fold it in half, and put it on the floor. and they'll take the paper and they just kind of futz with it and try and figure it out, and it just ends up being this mess. That they're not able to effectively manipulate the object as they used to be able to. So that's apraxia. And the last one is agnosia. So agnosia is impaired sensory function, again, despite intact sensory hardware. And so the way this will be tested clinically is we might have the person close their eyes. I want you to close your eyes. Close their eyes. And then we'll put like a quarter or a paper clip in their hand, something like that, and we'll ask them to identify the object, right? So again, they can, the question isn't, we don't drop a paper clip in their hand and say, can you feel this? Because they can feel it. The hardware is intact. But what they can't do is identify, right? So they can say, well, it feels, kind of hard and maybe a little flimsy, and it's like it's made of wire, but they can't identify it as being a paper clip or a quarter, perhaps. Okay? So again, the hardware is intact. They can feel the object. They can feel that it's cold or whatever, but they can't identify it. And so that would be an example of an agnostic. And then the last one, and we're going to talk so much about this in the next hour, is executive function. And so again, criteria 1 is you must have memory impairment. Criteria 2 is that you have to have aphasia, apraxia, agnosia, or executive function impairment. And so executive function impairment, executive function is your ability to plan, organize, sequence, monitor, and inhibit complex goal-directed behaviors. And so it's analogous to problems. So your problem-solving ability. When people become executively impaired, what happens is, there's a few things that happens. One thing that happens is that they become very dependent on their habits and their routines. And in fact, they become trapped by their habits and their routines. And as long as they're functioning within the habit and the routine, things usually go fine. It's when the habits break that disasters happen. Okay? And we're going to talk so much about executive functioning next time. The other thing that happens when people become executively impaired is that the environment starts to dictate their behaviors. So they can no longer behave independently from the environment. The environment starts telling them what to do, right? So if you're executively impaired, what does a doorknob tell you to do? Turn it, right? And walk through the door, right? If you're executively impaired, what does a piece of paper with an X and a line going across the bottom and a pen in your hand tell you to do? Sign. Right? Right? And so when people become executively impaired, they start to become, their behaviors start to be governed by the environment that they're in. This actually explains so many nursing home behaviors, problem nursing home behaviors. So you can imagine, if you're if you're a minute elder in a nursing home, and there's an elevator. Just thinking of some of the ones in town. There's an elevator with a button. What is that button telling you to do? Push it. And when the elevator goes, what does that tell you to do? Walk in, right? And then they'll say, well, he's trying to escape. He's trying to escape. He's trying to escape. Well, they're usually not trying to escape. It's just the elevator is telling them to escape, right? Okay. And so it's the elevator that's saying, hey, come this way, right? It also explains a lot of other behaviors. So, for example, if you're severely demented and you're on the floor, and you start turning, you see doorknobs. What do the doorknobs tell you to do? Turn, right? And then you walk in, and there's a hallway. And what does the hallway tell you to do? Walk down it. There's another doorknob, and you open that door, and that doorknob tells you to do. And then you walk into a room, and there's a woman lying in the bed. What does that tell you? Right? So, yeah, and so a lot of the problem behaviors in this case, for example, sexual behaviors are really governed within the environment that the person's in. So when people become executively impaired, their behaviors become governed by their environment, and they become trapped by their habits, Again, we'll talk a lot more about this. So, so all of the different, cognitions that we talked about are governed by specific parts within the brain. So executive function is governed by these prefrontal subcortical circuits within the brain. These are all brain structures. Memory is hippocampus, it's in the temporal lobes. Executive function is frontal lobe. The aphasic deficits that we'll see are specifically left frontal lobe. When they have the expressive aphasias, they can't get the words out. They have these diseases in the left frontal lobe specifically. The other speech deficit that can come out is in the same area, but on the right side are deficits of processing, where people fail to understand the tone of the speech. So, for example, they can understand the words, but they completely they don't understand the affect of the speech, and so they'll have these very kind of robotic speech patterns, and they'll also interpret speech in a robotic type way. And so this is so there'll be, for example, there'll be teachers, for example, who might have a stroke, a right frontal stroke, and they'll lose their job because they can't, even though they're not cognitively impaired per se, they'll lose their job because they cannot interpret the tone of the speech. So they lose control of their class, right? So when the student's saying, "Yes, Mrs. Johnson," they just hear, "Yes, Mrs. Johnson." And so they just lose total control of the class because they don't appreciate the process of the speech. So, then speech areas are left frontal lobe specifically, it's word finding problems. And then the motor strip and the sensory strips centered in the midline of the brain. So there are specific neuroanatomical regions that govern each of these deficits. And depending on how the brain is degenerating, depending on which areas of the brain are withering away, that foretells what cognitive deficits someone will have. Okay, so now we're going to talk about specific types of dementia. Again, I always tell people there really is 1,000 ways to be the ones we're going to talk about today are Alzheimer's, vascular Lewy body, frontotemporal dementia, and then we'll end the afternoon talking about alcohol-related dementias. So again, I'll hear things like, I'll hear, does this patient, does he have Alzheimer's disease or does he have dementia? And you can't think of it like that, right? Alzheimer's disease is a type of dementia. Or I'll be talking with a patient, I'll tell them, I think you have dementia, and they'll say, "Oh, thank God." I thought you were going to tell me I had Alzheimer's disease. That's right. And so, message of hope. Right? And so again, Alzheimer's disease, vascular dementia, Lewy body dementia, all of these are different types of dementia. And we'll go over 4 of these in detail. We'll start with Alzheimer's disease. So the hallmark features of Alzheimer's disease are that it's gradual, persistent cognitive decline. It has this sort of insidious onset. So if I'm working up a patient with Alzheimer's disease, I might have 3 family members in the room, and I'll ask the question, all right, when did y'all notice, how long has this been going on? How long have these memory deficits been going on? And they'll each have a different answer. One family member will say, "I remember a year ago that this one thing happened, and that's when I thought, I wonder if something's going on here." And then another family member will say, "Well, I think it's only been maybe the last 3 or 4 months that I've been noticing problems." And then the wife will say, "Well, I have noticed for 5 years now." Right? And so the family, the onset is just so gradual and sort of insidious that it's hard to pinpoint when the disease began. So this is in contrast to other types of dementia, like vascular dementia, for example, where people will be able to say, oh yeah, this starting 6 months ago, that's when the wheels started to fall off the wagon. And all the family members will say, yep, about 6 months ago, that's right. And so, so one of the hallmark features of Alzheimer's disease is that it is, it's just this gradual onset. And the other thing about Alzheimer's disease is that it's progressive. It's just continuous. So the prognosis for Alzheimer's disease is poor, right? There's only one way, and it's a downward trajectory. It's this continuous neurodegenerative. Cognitive deficits can be to other disorders. We typically divide it up into early onset or late onset. Late onset after the age of 65, early onset before the age of 65. The only reason that's really important is because it might inform the mechanisms that are causing the Alzheimer's disease. And so, just as you can think about depression as an example. So you can imagine there's lots of different pathways that, lots of different pathways and lots of different physiological changes that can lead someone to the common syndrome of depression. Similarly, there's lots of different biological changes that can happen that can lead someone to the syndrome of Alzheimer's disease, as it turns out. So again, back to depression, you can imagine that someone can be severely depressed, they can be depressed, have loss of interest, sleep disturbances, appetite changes, thoughts that life isn't worth living. They can have a major depressive disorder, but you can appreciate that the pathophysiology of someone who has major depressive disorder because they have, I'm going to say postpartum depression. They had a baby, now they have postpartum depression. The pathophysiology, the pathophysiological changes of postpartum depression is going to be very different from, say, a 70-year-old who had a stroke and is now depressed, right? They'll meet the same cluster of symptoms, depression, poor energy, poor appetite, sleep changes, all that. They'll meet the same cluster of symptoms, so they'll have the same disease, but there's different pathways to get to that disease, if you will, right? So the same is true for Alzheimer's disease. It has to do with the different pathological changes. The big thing with Alzheimer's disease versus early onset versus late onset is that early onset Alzheimer's disease is mediated much more by genetics, right? So when people say, my dad has Alzheimer's disease, what are the chances that I'm going to get it? The follow-up question is, well, how old was your dad when he developed Alzheimer's disease? And if they say, well, he was 80, then genetics is much less of a risk factor for the family. If the family member says, my dad was diagnosed with Alzheimer's disease at the age of 60, all of a sudden now genetics becomes much more important. Okay? So the only real help, if you will, or utility in early onset versus late onset is that early onset is much more heritable than late onset. The heritability of late onset Alzheimer's disease is very, very small. Okay. And so when we start to stage Alzheimer's disease, when we stage it behaviorally, early onset disease changes in orientation. They become more disoriented. They won't know it's always disorientation to time, followed by place, followed by person. They start with not being poorly oriented to time. They'll have personality changes, problems with routine tasks, problems with memory and judgment. And again, these changes are exacerbated by the environment. So in early stages of Alzheimer's disease, what are the personality changes that you see early on?
More irritable?
Yeah, that's right. It's irritability. Yeah, that's right. It's irritability and disinhibition and impulsivity, and it's kind of grumpy old man syndrome, right? Oh, these darn kids, get off my lawn, kind of thing, right? And so it's kind of it's a lot of the irritability, more accusatory of family members. As the disease progresses, though, what personality changes do you see more toward the end of the disease? Apathy, right? They're just much more apathetic. They don't, right? And so as different parts of the brain are degenerating, then different personality profiles manifest. And early on, it's certainly, as y'all say, the irritability that we'll see. Again, a lot of times the person will be functioning well in their home. So, for example, they could be preparing all of the meals themselves and doing a fine job at it, in fact. But if you take that elder and you put them in another kitchen, so say they go over to their son or daughter's house for Thanksgiving and they volunteer to, make the green bean casserole, all of a sudden it just becomes this, mess of an experience. And so early on, the deficits, when they're in their own home and their own routines, they're usually minimal. But when they pull them out and put them in different environments, all of a sudden it's, oh my God, I thought, my dad, he drives himself everywhere and there have never been any problems. Then I drove with him to go to some place we never drive to, and he was just this mess. Right? So the deficits are magnified by changes in that. As the disease progresses, you get more overt memory loss, more overt cognitive impairment, more overt anomia. And anomia is the word-finding problem. So they start to not be able to say what a chair is. They're trying to describe, well, this is what you sit in, and they can't get the word chair out. Much more apraxic deficits. They can't use their hands like they used to. They can become depressed. Psychosis is associated with the middle parts of the disease. All of the kind of very primitive reflexes that we have as babies start to come back. So there's all these primitive reflexes that babies have, really for survival purposes, that start to come back as the brain degenerates. So one of the primitive reflexes that comes back is a snout reflex. So if you take your finger and you put it at someone's lips and you tap them, right? You just kind of tap their lips. Like a non-demented person, nothing happens. You just tap their lips. But with snout reflexes, you can take a little baby or an elder with dementia, and if you tap their lips, they pucker, right? Their lips pucker out at you, right? So that's actually a nursing reflex. In babies, it's a nursing reflex. If their lips are touched, they go to latch is what they do. And so the same will be true in elders with dementia. If you tap their lips, they'll just pucker. And in the end stage of the disease, you don't even have to tap their lips anymore. As you just bring your finger toward their lips, they'll just start to pucker. You get this on the microphone, right? So their lips will start to pucker out as you even just start to bring your finger towards. Another example of a primitive reflex is a grasp reflex. So again, if you take a baby, if you just kind of stroke its palm, what the baby will do is it'll grasp on. It'll grasp like your finger or something like that. And again, in elders, this reflex comes back. If you stroke the palms of their hands, they'll just grab on. This becomes important behaviorally in nursing home management, because what you'll hear sometimes what nursing home nurses or staff will say is he grabbed me and wouldn't let go, right? He wouldn't let go, and it almost seems like it's meant that he's doing it on purpose. And a lot when patients develop this grasp reflex, it's not that he didn't let go. That's true. But it's what's more right is that he couldn't let go, in fact. The reflex fired, and they just can't let go, in fact. And so nursing home staff are trained how to manage those kinds of behaviors. As the disease continues to progress, we now get loss of speech, incontinence, appetite changes. They prefer, sweets as opposed to other types of food. Become bedridden. Seizures develop in about 10% of people with end-stage Alzheimer's disease. They develop these different postures, so they'll get what's called decorticate posturing, where if they're lying in bed, their arms pull up like this. So they're lying in bed with their arms kind of this flex type position that they just can't get out. And then they die. And so the most common cause of death in Alzheimer's patients are cardiac arrhythmias or pneumonia. And so those are the clinical progressions of the disease. When we start to try and assess them neuropsychologically, we'll put them through all these neuropsych tests. When we're trying to figure out if someone has Alzheimer's disease, there's two things we're looking for. The first thing we're looking for is, do they have non-promptable memory impairments? So if you have Alzheimer's disease, you have to have non-promptable. If you have non-promptable memory impairments, doesn't matter how many hints or clues I give you, the memory's not going to come back. The second kind of cognitive profile that we're looking at is the whole cortex of the brain affected, right? Do they have pan-cortical illness? So not just a piece of the brain is impaired, but the whole cortex is affected. And a nice way to assess this is with clock drawing, right? So we do lots of clock drawing tasks. And so in this task, what we do is we will give the patient a piece of paper, and we always say, I want you to draw a picture of a clock that says 1:45. Set the hands and numbers on the face of the child. And so then they, on this blank piece of paper, they will draw a clock to command. Then what we do is we flip the paper over, and then we draw a clock. And after we draw a clock, then we ask them just to copy the clock that we drew. Just look at it and copy it, okay? And so in this healthy, elderly retiree, you can see he has some tremor maybe, but what you can see is that this is his clock to command. He drew it to 1:45, and yeah, there's a tremor, but this is a pretty good clock, right? He gets a perfect score on this clock. And then we ask him to copy it, copy a clock that we had drawn, and again, a perfect score here. This is just a pentagon item. For those of you familiar with the mini mental state exam, this is the pentagon item. So when I tell a patient, I want you to draw a clock that says 1:45, put the hands and numbers on the face so the child can read them, what part of the brain is that probing? So it's executive function, right, which is frontal lobe, right? So drawing a clock to command is a frontal lobe task. When I draw a clock and I have them copy it, what part of the brain, what cognition is that testing, and what part of the brain? So that's visuospatial. That's just visuospatial skills. Just looking at something and copying it is visuospatial. And what part of the brain is visuospatial? Right posterior parietal. Okay, so the back part of the brain, specifically on the right side. Right posterior parietal is being able to look at a clock and just copy. And so what you can see in this patient here with Alzheimer's disease, he has frontal lobe impairment. He can't draw a clock to command, and even when I draw a clock for him and have the patient just copy it, he can't do that either, right? So he has frontal lobe impairment, he has posterior parietal impairment, he has evidence of pan-cortical disease. This is what we see in Alzheimer's. The whole cortex of the brain is affected. If this was a patient with, say Parkinson's disease, for example, what you would see, or Parkinson's dementia, what you would see is that they can't draw a clock to command. They have frontal lobe impairment, but when you ask them to copy a clock, they can do that fine. They can look at it and do that fine. Because Parkinson's disease doesn't affect this part of the brain. It doesn't affect the back part. It only affects the front. So, again, in Alzheimer's disease, they have pan-cortical. we can start to talk about, so what's causing disease? What are the theories behind Alzheimer's disease? And so the first theory that came out behind Alzheimer's disease is that it's loss of a neurotransmitter, a chemical in the brain called acetylcholine. What happened was that it was discovered that in patients with Parkinson's disease, Parkinson's dementia was caused by a deficiency of dopamine. It's a dopamine deficiency. And out came Cinemet, and patients with Parkinson's started taking this dopamine supplement, essentially, and their tremors improved, and the cog wheeling got better, and their symptoms improved. When Parkinson's disease was identified as a dementia with dopamine deficits, then the race was on to find, well, what is the neurotransmitter chemical deficit in Alzheimer's? And the one they stumbled on first is this chemical called acetylcholine. So right now, there are 5 medications that are FDA approved for Alzheimer's disease, 4 of which target acetylcholine. They prevent the breakdown of this chemical in the brain. So acetylcholine, what acetylcholine does is it helps with concentration and attention. So a good example of this, I won't ask you to identify yourselves, Kim Young. But, so a good example of this is among smokers. And so,
oh, man.
So people who smoke, what they'll notice is that, when they're smoking, that they're able to, that their concentration just seems to improve and their focusing improves. And that's because nicotine is latching onto these nicotinic receptors, which helps with attention and concentration and focus, in fact.
So it's a good thing then, right?
No, you should not. It's actually an interesting, I would have friends in medical school who would, when they were studying for their exams, they would actually do that. But the problem is that to make it work, you have to be able to smoke while you're taking the test. So it wouldn't work. So anyway, no, that's not what I'm saying. So anyways, when we start thinking about what might cause Alzheimer's disease, the original thought was that maybe it's a cholinergic deficit. The problem with the theory is that cholinergic neurons are dying actually way late in the disease. They're not dying early. Nonetheless, the rationale for medical therapy with Alzheimer's disease is all predicated upon this cholinergic hypothesis. So all of the medicines that you commonly hear about, donepezil, which is Aricept, ribostigmine, which is Exelon, galantamine, which is Razadyne, all of the medications that are commonly prescribed for Alzheimer's disease are targeting this chemical, trying to prevent the breakdown of acetylcholine. And I think most people agree that the effect size of these medications is pretty underwhelming. But nonetheless, that's the theory behind Aricept, Exelon, and Razadyne. When you look at how useful are these medicines for Alzheimer's disease, it's funny. You'll get so many different opinions. You can have an expert panel, an Alzheimer's disease expert panel, and within the same panel, say there's 7 people on the stage talking about Alzheimer's disease, the range of opinions will vary from these medications must be prescribed for patients with Alzheimer's disease, and if they're not prescribed, the physician is violating the standard of care. So there'll be that opinion all the way to these medications have absolutely no utility at all. They're an unnecessary cost in the healthcare system, and it's unethical to prescribe them because it's nothing but false hope. Right? And so within the same expert panel, you'll have this incredible range of opinion. I can just tell you anecdotally that it seems to me in my patients that about 1 in 8 seem to benefit. About 1 in 8. So I'm never excited to prescribe a medication. I never say, hey, have I got the therapy for you? But 1 in 8 is enough to where I always offer, right? It's always, maybe they'll be the 1 in 8, right? And so we don't want to withhold trees. So about 1 in 8 is what I see in those settings. And there's no difference. This is data supporting HRSA. I won't go into all this stuff here, but there's not a lot of difference between any of them. So it's not like Razodine is better than Exelon or Exelon's better than HRSA. The only real difference between them is different side effect tolerabilities. The other idea behind Alzheimer's disease that that came out afterwards was sort of an oxidative stress hypothesis, and this is the theory that that Namenda or memantine, which is also FDA approved for Alzheimer's disease, was built upon. So the theory was that as the neuron is aging, its membrane becomes more permeable. And as its membrane, the cell membrane becomes more permeable, it becomes more vulnerable to oxidative stress. So the idea was that it's oxidative stress, kind of free radical damage that is killing off the neurons. And so there's different receptors on the membrane of a nerve cell that let in different messengers. And the big messenger that comes in through these is calcium. And so what we know is that if too much calcium is getting into the nerve cell, the calcium triggers this chain reaction that can ultimately kill the cell. So I always have to be careful when I talk to patients about this, because what they hear is, oh, calcium's bad for you. So then they stop taking their calcium supplements, and then they fall, then they have hip fractures, and I promise you hip fractures is really bad for your cognitive state also. So I say, no, you have to keep taking your calcium. But the idea was that it's free radical damage that is killing the nerve cell. And so the medication memantine, which was Namenda, basically puts the brakes on that. Namenda prevents calcium from entering the nerve cell, and therefore it might be neuroprotective. Again, I think most clinicians are underwhelmed by its effect size as well, right? It doesn't seem to do any better than Aricept or Razodine or Exelon. So the challenge with all of these medications for Alzheimer's is that they all have demonstrated efficacy, but the effect size is small for all of them. These are not miracle cures. And the other truth behind them is that they're all intended to slow the progression of the disease, not to treat the disease, right? They're not going after pathology. So when you look at, what does someone's brain look like with Alzheimer's disease? This is what you see. So this is the gross brain. And so what you'll see, so we have the normal brain over here on the left side of the screen. This is an Alzheimer's brain. And so what you see is that as the brain ages, not as it ages, but as it degenerates with Alzheimer's, it just gets smaller and smaller and smaller, right? So you can just appreciate how much smaller. You can just see this ventricular, this is the ventricle, right? Here's how much larger this ventricle is compared to that. This right here is a normal hippocampus where memories are encoded. And you can see the hippocampus here is just obliterated. These are the language centers. Again, good, healthy language tissue here. And again, it's just withered away here. So that's what you see if you look at a brain, just cut it in half and you look at it grossly. If you look at it under the microscope, the two pathological changes you'll see with Alzheimer's disease are tangles and plaques. And so the tangles are intracellular. It's like the nerve cell fills up with this protein. That protein kills the nerve cell. And then plaques these are amyloid plaques. So you hear amyloid, beta amyloid plaques. And so amyloid is another protein, but it's excreted out of the cell. And this protein is really sticky and just forms these clumps of what are called plaque in the brain. So when you look at how these plaques, how the tangles spread, it's not a random distribution within the brain. It's actually a very sequential spread of the tangles through the brain. So where is the very first place in your brain do you think that tangles happen? The nose, right? Pre-olfactory cortex. Pre-olfactory. So the very first place that tangles appear is in pre-olfactory cortex, right? The part of your brain that identifies smells. So one of the ways when patients are coming to us, we'll sometimes we'll smell test. And again, the question isn't, so we might get like a peppermint or something like that. And the question isn't, can you smell this? Because they can smell something. The question is, what does this smell like? And if they can identify the smell, then we know they don't have Alzheimer's. If they can't identify the smell, it doesn't mean that they have Alzheimer's disease, because there's a lot of reasons why someone may not be able to identify the smell. But nonetheless, if they can, then we can pretty much scratch that off the list. So the very first place in the brain that has tangles is the part of your brain that identifies smell. And in fact, 40% of 40-year-olds already have tangles in that part of the brain, right? So are they demented? Maybe they don't. I know. Right, so, but most of them are not demented because they don't have disease in their hippocampus, or they don't have disease in their memory structures or their executive centers or anything like that, right? It's just confined. They can't identify smells, but big deal. What will happen is that the tangles will then spread a few steps down the road into the memory centers, right? So they'll spread into the memory centers. So now the person will have start to develop these memory deficits. A lot of times it starts with names. They'll have a hard time with names, and they might forget other little things. Are they demented now? Now, they're not demented yet because they're not functionally impaired yet. So they have memory problems, but they're not yet demented. They're not functionally impaired. And again, you can't be demented unless you have functional impairments. Right? From there, they'll spread into a structure called the amygdala, and now we get the kind of the grumpy old man syndrome, right? The amygdala is the part of your brain that that lights up in disgust and fear and anxiety type centers. So now they'll invade the amygdala. So now you have a grumpy old man with memory problems. Is he demented? Not yet, not functionally. After they jump out of the amygdala, then they go into the frontal lobe. They become executively impaired. Once they become executively impaired, they become functionally impaired, and now they have dementia. So we don't, the learning point here is that we don't diagnose dementia until it's spread to the very last stage of the brain. No, it's not when there's disease and all these upstream brain organelles. It's just kind of personality changes and some mild memory problems. So it's actually not till very late in the pathological portion of disease that Alzheimer's in fact is diagnosed.
Is that a good thing though? To wait until it's at that stage?
If there was something to prevent it, then it would be good to diagnose it early.
Oh, it slows it down.
Yeah.
So it would be better.
But no. So if there was something to prevent the spread of tangles, if something could prevent these from progressing through the brain, that would be good.
You said it slows it down.
Well, that was like HRSA. That's a different. That's targeting neurotransmitters, not pathology. It's different. But you're right. If there was a medication that could slow down tangles, that would be good. And what they were hoping was that there would be medication that would slow down, that plaque would be the same. We could slow the progression of plaque through the brain. Then that would be, that could prevent Alzheimer's disease, if not significantly hurt it. And that's when amyloid came out. So you'll hear about amyloid. Again, it's this protein that's excreted out of the nerve cells into the matrix of the brain. A lot of the, there's this big flurry in the media over the last 10 years, where medications were developed to prevent the spread of this pathology. Unfortunately, all those studies failed. They've all failed. It's a nice example of how animal models don't mimic human disease. So what happened, all of the hope for the disease was based on their success in animal models, specifically in mice, in fact. So all these medications are first beta tested in rats and in mice. And the problem is that in the natural world, mice actually don't get Alzheimer's disease. This is the problem. So they had all these kind of genetically mutated mice that were spreading out all this protein, and so they kind of created mouse models of Alzheimer's disease, but they just didn't work out. And so in the natural world, what animals get Alzheimer's disease? You know? Not pigs, not elephants, not even chimpanzees. That's a good guess, but certain humans. But yeah, no, it's goats, sheep, and cows actually. So yeah, goats, sheep, and cows are the only animals that get the Alzheimer's pathology in the natural world, right? Which explains a lot. Test what? No, it's tested biological. So what will happen, for example, is there'll be some sort of cow disease, and they're trying to figure out what the cow disease is, and they pull the brain out, and they look at it under a microscope, and lo and behold, there's evidence of Alzheimer's pathology. So for example, they're looking at mad cow disease, infected meats, that kind of thing, and it's discovered and something like that. Yeah, no one goes looking for it. It's just, it's just sort of incidentally found. Yeah. It's like a traumatic cow brain injury. No. So it's all discovered. But as it turns out, those are the only. So then, and then it just kind of piques curiosity, and then so people start looking. And so then kind of when we start thinking about what might cause Alzheimer's disease, kind of the leading hypotheses now are that it's caused by a virus. And the leading viral candidate right now is herpes, actually, herpes viruses. And so what we know about herpes viruses is that they specifically, what we know about herpes viruses is that they specifically target neural tissue. They specifically target nerve tissue. So when you get chickenpox, for example, chickenpox is actually a type of a herpes virus. It specifically targets, in this case, the spinal cord tissue, and that travels out to the peripheral nerves, and you get all these kind of pockmarks on your head. And so we know that herpes viruses specifically target neural tissue, and we know that herpes viruses specifically spread sequentially through nervous tissue, just as Alzheimer's disease specifically spreads through nervous tissue. When you start to look at symptom clusters, how does herpes simplex encephalitis, for example, compare with the symptoms of Alzheimer's disease? What brain regions does it affect? What are the risk factors for both? They're essentially all the same, right? They're affecting the same parts of the brain, the same risk factors, and the same personality, the same clinical presentation. It's just herpes simplex encephalitis is just in overdrive. Right? Alzheimer's is much more slow. When you look at risk factor genes like the APOE4 allele, you'll hear about APOE4, and sometimes you'll read that in the paper. If you take someone who has this gene, so if you take someone who has Alzheimer's disease, and then you do a blood test, and you see who is HSV positive, herpes simplex virus positive, or herpes simplex virus negative, what you'll see is that if you have Alzheimer's disease and you're herpes simplex virus positive, 53% have the strongest risk factor gene for Alzheimer's disease. diseases. 52% have this APO4. If you look at cold sores are also caused by herpes viruses as well. So if you look at, what percent of cold sore sufferers have this risk factor gene for Alzheimer's, again, it's 30% of cold sore sufferers have it compared to only 8% of non-cold sore sufferers. So there's just sort of this accumulating body of evidence that maybe Alzheimer's disease is caused by a virus, and maybe that virus is a type of herpes virus. This is a whole slide about genetics. What I'm going to say about genetics is that it's only relevant in young onset, right? So again, when people ask me, my dad has genetics, is there a chance I can get it? I always ask, how old was your dad when he was diagnosed? If he was diagnosed after the age of 65, genetics just doesn't seem to matter. It's not as the heritability is small. If it was diagnosed after the age of 65. So that's a lot of Alzheimer's disease. All right, so we'll move on to the other few types here. We'll move on to vascular dementia. So vascular dementia is not relentlessly progressive. With vascular dementia, what will happen is that someone will be at a given level of functioning and cognition, and then they'll have a small, tiny stroke in the frontal part of their brain, and they'll stair-step down to a new level of cognitive and functional state. And then they'll stay there until they have another small, tiny stroke. They'll step down. And so with Alzheimer's disease, it's more of a step-down progression as opposed to just this continuous, unrelenting progression of disease. And the truth is that as long as someone doesn't have another stroke, then they'll stay at that same level, right? It's not inherently progressive. So when we start to think about, what can we do to protect our brains, without a doubt, what we can do is keep oxygen flowing to the brain, and that means exercise, right? So when people say, what can I do to prevent dementia? What can I do? Can I do what everybody wants to do is crossword puzzles. People don't like the idea like sitting in a nice chair, watching TV, I guess, and doing crossword puzzles. Crossword puzzles will get you nowhere. If you really want to protect your brain, it's exercise. It's getting blood flowing to the front part of your brain to prevent vascular lesions. So in vascular dementia, it's more of a step-stair pattern, and then the other kind of feature of it is that they have these promptable memory impairments. So their memory doesn't seem that bad. If you give them hints or clues, the memories come back. And then they always have evidence of lots of different medical comorbidities. What's interesting about Alzheimer's disease is that patients who really have Alzheimer's, they're always strangely healthy otherwise. It's like they have Alzheimer's disease, but they don't have diabetes, they don't have high blood pressure, they don't have high cholesterol. If it weren't for these pesky memory problems, they would be fine, right? So Alzheimer's patients are always strangely healthy. Vascular dementia patients aren't. They have diabetes, they have hypertension, they have high cholesterol, they have a history of heart attacks, they have atrial fibrillation. They have all of these vascular risk factors. Again, if you do clock drawing tests with them, what you'll see is that they have executive deficits. They can't draw a clock to command, so they're failing the, I want you to draw a clock that says 1:45. But if we ask them to copy a clock, they do that fine, right? So they don't have pan-cortical disease. All of their disease is confined to frontal lobe, okay? So they have a whole different cognitive profile. If you look at their brains grossly, I don't know if you can see this on the screen, but all these like little kind of purplish looking dots, it seems like you can see these little dots that you see, those are strokes. All those little dots, let's see if I can show you. All these little, all those little those are strokes. Those little dots, they are strokes. All of them are dots. So, yeah, those are dead areas. And so, again, they just start to accumulate. If you have one, it's no big deal. If you have two, it's no big deal. But the problem is the more you have, as they accumulate, it becomes a bigger and bigger and bigger deal until you get dementia. If you look at their brains under, this is an MRI, these white patches, these kind of bright white patches, those are strokes, right? You shouldn't have these white, white hot areas in the middle of the brain. These are all stroke. So again, if you have a stroke right here, for example, that's not affecting motor centers. So although these are strokes, you don't see them physically. They don't have any paralysis or sensory deficits because the strokes aren't occurring on the surface. They're occurring deep within the brain. So that's what we'll see in our vascular. Lewy body dementia is probably the one. It's interesting with Lewy body dementia. This is probably the one that probably has the most association with a lot of the APS problems that we see in that. Specifically with hoarding type behaviors, and also the elders that die in the heat of the Texas sun every summer. And so with Lewy body dementia, you have to meet all the symptoms for dementia, but then you have to have this triad of findings. You have to have Parkinsonism, confusional spells, or visual hallucinations. So if you have 2 or 3 of those, then you meet the criteria for Lewy body. So the visual, we'll start with the Parkinsonism. So again, you have to have 2 or 3 findings. The Parkinsonism, visual hallucinations, or these fluctuations. Parkinsonism, the kind of classic sign of Parkinsonism is this pill rolling tremor, right? They just kind of do this, and they have this real profound tremor. A lot of times in Lewy body dementia, the Parkinson's signs are much more subtle. So what we'll, instead of seeing of the tremor, we're more likely to see the stiffness. So their arms are just kind of rigid and kind of cogwheel back and forth. The other thing that we'll see is in the way they walk. So in the Lewy body patients, the way their Parkinsonism will manifest is when they walk, they lose that. So normally when you walk, you kind of swing your arms. So in the Parkinson's cases, they lose that. They no longer swing their arms. They kind of walk almost kind of robotic-like. And then they also kind of shuffle their feet along the carpet instead of picking up their feet as they walk. So they have a shuffling gait. They lose their arm swing. They get more rigid. They lose facial expression. Those are the Parkinsonistic signs that we see. They fall all the time. It really should be another criteria. They fall so often that it should be added to the criteria. The visual hallucinations are incredible. So again, these aren't, the visual hallucinations aren't things like, I see shadows out the corners of my eyes. That's not it. The visual hallucinations are, I see a child sitting right here in my room. There's a child, right? It's incredibly formed, well-formed, clear delusions. Or they'll see, like little munchkin people walking along the mantle. Or they'll see, a lot of times it's also animals. It's like, who let all these cats in? I told you, don't close the door. The cats are going to get in the house, right? And so, so just incredibly well-formed visual hallucinations. The fluctuations, it's interesting. We'll ask families sometimes. We'll ask families, does your loved one ever have spells? And if the family says, well, what's a spell? Well, then the answer's no, right? And so, but a lot of times, if you just ask a vague question, do they ever have spells? They'll say, oh, yes. And what they'll tell you is that there's times where their loved one is just completely lucid, doing very well, and then like a light switch goes off and they're lost in space and confused and disoriented, and so this is the fluctuations. Again, to have Lewy body, you have to have 2 or 3. Parkinson's, Parkinson's visual hallucinations, and then these fluctuations. Other features, as was already stated, are falls. These patients fall all the time. I mean, they are, without a doubt, they are the fallers. They also have these REM sleep disturbances, so these are the ones who talk out in their sleep at night. In fact, probably the earliest sign of Lewy body dementia is sleep talking, right? It happens like 50s, right? And so the earliest sign is, in fact, is sleep talking. So sleep talking can happen, 20 or 30 years before the onset of the actual. These are ones that are, floundering in bed, kicking, and all that different stuff. You look at it under a microscope. This is a Lewy body. So it has its own pathology that's different, really purple glow there. It has its own pathology different from Alzheimer's. And again, with kind of related to APS work, it's the Lewy body patients that also seem to hoard. They hoard. You go into a nursing home of someone with Lewy body, they like hoarded all the butter packets, or all the sugar packets, or all the, just you open a drawer and there's just like crap everywhere, like flies. The other thing about Lewy body dementia is that their whole autonomic nervous system is just turned upside down. So these are the patients that have, they have incontinence or constipation or diarrhea. They're the ones that have heartburn and reflux. They're the ones that have cardiac arrhythmias like atrial fibrillation. Their whole autonomic nervous system is just turned upside down on its head. And when we start to think about, we'll hear cases, or we'll go into homes, right? I mean, we'll go into homes, do APS home visits, and you'll walk into a home and it'll be 100 degrees outside, and the home is sealed up, and it's like a this sauna inside the home, and the elder will just be sitting there, like not even noticing it, right? And it's like, how can you be here? And so again, what I think is going on is that their whole autonomic nervous system just is not registering, and these are the ones that I think are more vulnerable to dying in the context of sun than patients with Alzheimer's or actually, but they just don't feel it. All right. So then the last one that we'll talk about is frontotemporal dementia. So in frontotemporal dementia, what you can see is that the front part of the brain is just withered away, right? So what you see is that this is a frontal lobe, and it's just gone. I mean, it's just so small, compared to the back part of the brain, right? That's like healthy tissue, healthy spacing, and up here, it's gone, right? And so frontotemporal dementia is what affects, it tends to be what we see in younger people. So it strikes around the age of 60, right? And the way that it comes to manifest is a lot of times we'll get a referral to our clinic for a 60-year-old with new onset bipolar disorder, right? And you can't get bipolar disorder from out of nowhere at the age of 60. It's a developmental issue. But nonetheless, their behaviors are so disorganized. Their personality changes are so marked. There's so much impulsivity and disinhibition that it kind of look like bipolar disorder. So with our frontotemporal dementia cases, it's what we see in the young people. Their memories are actually very good, as it turns out, because the memory centers are in hippocampus. They're in the temporal lobe. So the dementia hasn't yet progressed to the temporal lobe, but their executive processes are awful. I mean, they have no executive function at all, in fact. That part of the brain is just gone. And then in addition, because the frontal lobe is just withering, they're the ones that have terrible aphasia. I mean, they just cannot get the words out to say their lines. So again, for this first talk, what I want you to appreciate is that dementia is the broad category. There's a lot of different types of dementia. You can't say, their memory seems okay, it's not too bad. they can still have dementia, even if their memory doesn't seem that bad. It's just they may have a promptable memory impairment as opposed to Alzheimer's disease, non-promptable. It's very easy to see. And then that's it. I mean, those are the main things I want you to see. So there's just different types of ways to be dementia.
I was wondering, do you know the cause for this one? I mean, are there some?
No, no one knows the cause of spring, except for vascular. Yeah, that's right. Yeah, it's analogous to cancer, right? It's like, oh, God, thank God you told me I have melanoma. I thought you were going to tell me I have cancer, right? Yeah, no, that's exactly right. That's a nice analogy. Yeah. Other questions?
Yeah. On the Lewy body, you stated that the people who can have that symptom where the heat in the home, and what I've heard, what I've come across is that people that were raised in the rural area, that didn't have a center, and they moved in town, they don't necessarily have certain conditions.
Yeah.
People like that.
Yeah.
I come across it all the time.
Right, so you have to keep the cultural context within the framework. So the patients who, you're absolutely, the ones who grew up without these amenities and then or never used the amenities, well, then they can become trapped by their habits and not use them now. So you're absolutely right. You have to, you have to keep in mind the cultural framework within which your patient is living and developing.
I think I heard you say that 1 in 8 of your clients, there's a medication that some sort of. Is there a study on those 1 person that why are they accepting?
Yeah, yeah. Why might they respond better than others? No. I mean, there are studies, but no one knows. I mean, there's no definitive. The group that seems to benefit the most from those medications is the patients with Lewy body dementia. So patients with Lewy body dementia really do seem to benefit more from these acetylcholinesterase inhibitors like Aricept, Razodone, Dexamethasone. And that's the reason for that is because cholinergic tone is lost early in the course of Lewy body dementia, where it's lost late in the course of Alzheimer's disease. So yeah.
I need to mention the period of time from the progression of stage 1 to stage 2, the very late stage. Any research? Was that data?
So on the progression of the disease, so from the time of diagnosis until the time of death, the average time is about, well, it's 5 to 10 years, depending on the study you're looking at. It's really probably closer to 10 years in fact, because we've gotten better at diagnosing. Because we've gotten better at diagnosing it early, then now it's 10 years. It used to be about 5 years because we wouldn't diagnose it until late. And so right now, from the time of diagnosis until death, is about 10 years on average.
And the best test for someone with these signs would be an MRI, CAT scan, or just what?
Yeah, so that's another important point. So people will ask, what is the test, right? Is it an MRI? Is it a CAT scan? Is there a lab? And the answer is no. So there's no, that's not how it's diagnosed. It's diagnosed based purely on clinical symptoms and the neuropsychological performance. The reason we get the labs and the MRI is it's not to diagnose Alzheimer's disease per se, it's to rule out other things. So in a typical dementia workup, we'll get a CBC to make sure that they don't have anemia, right? People do not function well cognitively if they're anemic. So we're going to make sure that they don't have anemia. We're going to check their vitamin levels, B12 and folate. We don't want them to be nutritionally depleted, and that's what's explaining it. So we're checking labs like that. We're making sure they don't have syphilis. We're making sure that their thyroid is functioning well. So all of the serum labs are to rule out other medical conditions that could be causing the same symptom cluster. Same with the MRI. The reason we get an MRI is to make sure there's not, so for example, maybe they had a fall and there's this big bleed up in their head that could be evacuated and then they could get better. When we get the MRI, we're making sure they don't have hydrocephalus, that the ventricles in their brain don't have too much fluid in them, if you will, and are putting pressure on the system. So the reason for the MRI isn't to diagnose Alzheimer's disease. The reason for the MRI is to make sure that they don't have something else that could be so easily treated, right? So in the same way that it would be awful to treat someone, if someone has hypothyroid and their depression is from their hypothyroid, it would be awful to be treating that person with Prozac when they should be treated with Synthroid, right? Thyroid replacement. The same would be true in Alzheimer's. It's terrible to treat someone with Arisab when they should just have their thyroid fixed. Right? So that's why we get all these other labs.
Do you see a lot of misdiagnosis? Because what we see sometimes is a primary care physician. The person comes in, maybe multiple symptoms, but not to cast aspersions on internal medicine, but they just focus on the memory loss and they say you have Alzheimer's. But it doesn't explain, of course, all of the other symptoms. Do you see a lot of?
Yeah, I mean, the answer is yes. Yeah, we do see that a lot. And it can have really significant impacts. So, for example, the biggest, probably the most dangerous mistake is when someone has vascular dementia and they're misdiagnosed with Alzheimer's. And it's all about the treatment, right? So in Alzheimer's disease, you're increasing, if you take the treatment for it, you're increasing cholinergic tone. Well, if someone has vascular dementia, if they have enough cerebrovascular disease in their brain to cause dementia, chances are really good that they have lots of vascular disease in their heart as well. And if you increase cholinergic tone in the heart, you're slowing it down. And so you're putting them at risk for heart block and, in fact, death is what you're. So when you start to look at the potential risks and benefits of the medications, in Alzheimer's disease, they may be low benefit, but they're also low risk. In vascular dementia, they're low benefit, but they're higher risk. And so, yeah, it really is important to do it.
And that's where you come up with the mini strokes and vascular.
Yes, sir.
I would think that would be difficult for someone who lives on their own to know that they have a real small mini stroke.
They don't know.
I know.
Because you don't feel it.
Yeah.
Yeah, I mean, you don't feel it.
And they think that they recover, if they do, they recover so quickly.
Yeah.
Because I've heard of someone having a small stroke, and the next day it was.
Yeah. Right. So they call it a TIA. It was transient. Well, it was transient in terms of their peripheral loss. So maybe they had numbness in their fingers, and that came back, and that was transient. But the cognitive deficits aren't transient.
So it still would be this
Spot.
spot.
Yeah.
Right.
Well, why don't we take a 15-minute break, and then we'll come back.
Just a 15-minute break. Resume at 10:45. The bathrooms, you guys are past elevators on the right, and right across the hallway is a sanctuary. Women's bathrooms. I don't know whether that's Across the hallway. Any questions about CE?
How did it go?
Oh, we went.
Good? No problem?
I'm walking too far ahead, and you're calling to me. I can't hear what you said. You said it goes slow. I'm far behind.